This hearing will come to order. As this hearing is fully virtual, we must address a few housekeeping matters. For today's meeting, the chair or staff designated by the chair may mute participants' microphones when they are not under recognition for the purposes of eliminating inadvertent background noise. Members are responsible for muting and unmuting themselves. If I notice that you have not unmuted yourself, I will ask you if you would like the staff to unmute you. If you indicate approval by nodding, staff will unmute your microphone. I remind all members and witnesses that the 5-minute clock still applies. If there is a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. You will notice a clock on your screen that will show how much time is remaining. At 1 minute remaining, the clock will turn yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time is almost expired. When your time has expired, the clock will turn red and I will begin to recognize the next member. In terms of the speaking order, we will begin with the chair and ranking member, then members present at the time the hearing is called to order will be recognized in order of seniority. And finally, members not present at the time the hearing is called to order. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings or markups. That email address has been provided in advance to your staff. With that, I would want to acknowledge Congressman Harris, who is serving as ranking member today for this hearing in Congressman Cole's absence. And I also want to thank all of our colleagues for joining. I am pleased to have the Center for Disease Control and Prevention leadership back before the subcommittee to discuss the current state of the pandemic and our nation's response, and the President's budget request for fiscal year 2022 for the CDC. On February 23rd, this subcommittee held a roundtable session with CDC focused on the COVID-19 response, and a day later, we held a hearing focused on public health infrastructure. Since that roundtable and hearing in February, our nation's response to COVID-19 has made significant advancements. Vaccines are now widely available. One vaccine is now approved for those aged 12 and above. Nearly 300 million vaccine doses have been administered, including nearly 4 million in my home state of Connecticut. Last week, we heard from the Yale New Haven Health System that they are now treating and I quote, staggeringly small number of COVID patients. This is a tremendous accomplishment. Our public health workers are finally able to sleep again. Our families are finally breathing a sigh of relief, and our workforce and our economy are beginning to rebound. But the messages from the public health infrastructure hearing in February were clear. COVID-19 exposed numerous realities in our nation, including that our nation's public health infrastructure is extremely fragile. Many health departments are still using fax machines or doing data entry by hand. Information about patients' names, sex, or pregnancy status are not being shared across departments. Health workers are leaving the field in droves, while others need workforce development. And our research labs are struggling to find the equipment, capacity, and trained workforce they need. But now communities are realizing that our public health partners are essential, not only for infectious diseases, but for health promotion and protection to keep our communities healthy and functioning. Our nation's public health system can no longer only get attention during a crisis. We must invest in the public health workforce, laboratories, and data modernization, not just to respond to the pandemic, but every year. After this pandemic is over, our public health agencies cannot go back to where they were. We need to meet this moment and build a public health architecture to move our public health partners and workforce forward. Today's hearing is the next step in turning those recommendations into action. While we will not receive the details of the President's budget until later this week, we know from the budget blueprint that the administration is requesting $8.7 billion, an increase of $1.6 billion over 2021 enacted for the CDC. The administration has described this request as, and I quote, the largest increase in budget authority for CDC in nearly 2 decades. But while this is a very welcome increase, I think in general we need to consider increasing investments for the CDC, not just year, but every year. As I've said many times, one-time investments do not ensure the CDC and our public health departments are ready to address chronic challenges. And we need to ensure our public health infrastructure is ready to address the challenges or pandemics of the future. This COVID-19 pandemic has only further underscored the need to view public health infrastructure as a fundamental service, not just something we fund when the need arises. The tide has turned. We need to start providing funding to address core public health activities. While I look forward to receiving detailed requests for CDC, the programs highlighted to receive increases in the summary released in April are very welcome. Maternal mortality prevention, firearm injury and mortality prevention research, climate and health, social determinants of health, and the establishment of a new community-based violence intervention program. In terms of gun violence research, I am particularly interested in getting a progress report. I know it may be too early, but I hope that you can let us know a little more about the status of gun violence research and what we have learned. In terms of maternal mortality prevention, I also want to say that I'm pleased to see increased investments in research on maternal health to address the crisis of maternal mortality in the U.S. We absolutely need to make this a nationwide effort. Not one more mother should die just for participating in the miracle of birth. I also think the increased funding for research on how to reduce racial and ethnic disparities in maternal health outcomes and improving maternal mental health is particularly crucial. I might add that 2 weeks ago, the CDC made a significant update to its guidance that fully vaccinated people no longer need to wear a mask or physically distance in most situations. Dr. Walensky committed to leading the CDC with science, and I know that we will have a lot of questions about the current scientific evidence that led to this updated guidance and the subsequent guidance that we are all awaiting to be updated by CDC. I know that many people I have spoken to are still uncomfortable with this change and are not confident that being around people who are unmasked is safe. There is still a lot of uncertainty about the nuances that may be implied in such guidance. Throughout this pandemic, CDC has been in the unenviable position of making black and white recommendations in a world of gray areas. So I think it will be helpful to drill down on what this guidance means and how we can continue to restore public confidence in such guidelines. That is why I greatly look forward to today's discussion. Now, let me turn to my colleague, Congressman Harris, for any opening remarks that he may have.
Thank you very much, Madam Chair, and good morning, Dr. Walensky. Thank you for coming before the subcommittee this morning. Before I begin, I want to recognize the outstanding work and careers of Drs. Ann Schuchat and Nancy Messonnier, 2 longtime CDC physicians who have both recently announced their departures. I want to thank both of these remarkable scientists for their public service, dedication, and commitment to public health, especially during the COVID pandemic. You will both be missed. Just over 14 months since the COVID pandemic began, it's finally winding down in America. I think it's worth recognizing once again the stunning success that rapidly bringing a COVID-19 vaccine to market has had on the trajectory of this disease in America. The COVID-19 vaccines are the most quickly developed vaccines in history, thanks not only to the skill of researchers at Pfizer, Moderna, and other manufacturers, but also due to the work of Operation Warp Speed under the previous administration. Operation Warp Speed set our country up for the outstanding results of our current vaccination efforts. It's been a pleasure for me personally to lend a hand to help get Marylanders vaccinated, and I continue to encourage everyone to get vaccinated as soon as they can. The vaccines are relatively safe and effective and are enabling us to resume our normal lives quickly. On that note, I was glad to see that the CDC finally began to follow the science and recognize that vaccinated individuals can safely resume activities. Studies have shown for months that vaccines are effective and that outdoor transmission is almost non-existent. I continue to question why the CDC resisted making these statements for so long, why many of our schools continue to be closed, why the mask mandate continues in the House of Representatives, and why children in outdoor camps this summer need to wear a mask. One wonders whether pressure from teachers' unions and the need to distract from other difficulties facing our nation, such as growing inflation, spiking gasoline prices, renewed conflict in the Middle East, have influenced this public health guidance on schools. I certainly hope this is not the case, but the timing and information about the influence that teachers' unions had on CDC guidance are troubling. A key part of our transition back to normalcy will rely on fully reopening our schools. Census data shows that 50 million working Americans have children who are school age or younger. For many of these individuals, schools are the primary form of childcare. As such, it is imperative that all schools fully reopen immediately, not only so parents are not forced to choose between working and caring for their children, but also so that the children can continue learning in the best educational environment. Children with disabilities and those without as many resources at home have been robbed of over a year of academic, social, and emotional growth during this pandemic. But the science is clear. We need to bring these children back into the classroom now. These are important issues to discuss, and I'm sure there will be questions about them this morning. But let me briefly touch on the FY22 budget request before I conclude my remarks. The FY22 request contains the largest budget authority increase in CDC in nearly 20 years. You're asking for funding to enhance state and local public health infrastructure, as well as to build international capacity to detect and respond to emerging global biological threats. I support many of these efforts. As an obstetric anesthesiologist, for instance, I especially support the focus on reducing maternal mortality and morbidity. But I do question the magnitude of these increases in a single year, especially when overlaid on top of the billions of dollars provided in emergency COVID relief bills last year. I also question whether some of the funding items highlighted in your request are outside of CDC's core mission. For example, the budget will request double the amount of funding for firearm prevention research. You're also asking for $110 million for CDC's Climate and Health Program, a 1,000% increase to, quote, identify potential health effects associated with climate change and implement health adaptation plans. Are these kind of activities in the same priority category as combating COVID or other chronic diseases that threaten our most vulnerable populations, or reducing antibiotic resistance? I would argue that they're not, and that we should focus our CDC resources on communicable and chronic diseases rather than on controversial, politically charged activities. I look forward to the hearing this morning, and I yield back the balance of my time.
With that, I would like to again welcome and introduce our witnesses. Dr. Rochelle Walensky, Director, Centers for the Disease Control and Prevention. Good morning and welcome, Dr. Walensky, and many thanks for the outstanding work that you have been doing and really using science as your guide to particularly with regard to COVID and the manner in which we should proceed. And we're grateful for that guidance and really returning the CDC to its former past and being drivers of science and letting the CDC and not politics engage in the direction that we take a pandemic or any other illness. Dr. Ann Schuchat, Principal Deputy Director, Center for Disease Control and Prevention. As my colleague has mentioned, you recently announced your plans to retire Dr. Schuchat after 33 years at the CDC. I say thank you to you for your dedication, for your public service. We have been on many times, whether it was Ebola or whether it was the lead poisoning of our children in Michigan and other areas. You have a stellar career, and we are delighted to have you once again before this subcommittee. And Dr. Walensky, your full written testimony will be included in the record. You are now recognized for 5 minutes for your opening statement.
Good morning. Thank you very much. Good morning, Chairwoman DeLauro, Dr. Harris, and distinguished members of the committee. Thank you for your support of CDC. I'm here today, as you note, with Dr. Ann Schuchat, CDC's Principal Deputy Director. I have enormous gratitude for Dr. Shukit's leadership and contributions over 3 decades, as well as during this very challenging time for our country and for her rock-solid support of me in my transition into this role. Anne embodies selfless public service, the pinnacle of scientific and intellectual standards, and has given her heart to our agency and to the public health community. I will be forever grateful that I had the opportunity to work with Anne, even just during this brief period of time. The COVID-19 pandemic threw the United States and the world into a health, economic, and humanitarian crisis. As the crisis unfolded, it put a spotlight on the fragility of our public health infrastructure. It illuminated great disparities in health outcomes by race and ethnicity, reminding us that, thus far, we have failed to address the systemic racism that results in poorer health for people of color in the United States. I am committed to working with you, the administration, and our public health partners to ensure that every lesson from this horrible crisis is used to build a better, stronger, healthier America. I also commit to using our public health expertise and experience in partnership with the global community to move the world into a safer, healthier future. CDC's fiscal year 2022 discretionary budget request of $8.7 billion is an increase, as noted, of $1.6 billion over fiscal year 2021, the largest increase CDC has received in nearly 20 years. The increases focus on 4 critical areas: building public health infrastructure, reducing health disparities, using public health approaches to reduce violence, and defeating diseases and epidemics. These increases build on the investments made in the COVID-19 supplements and are an important first step in addressing deficits in the public health infrastructure. COVID-19 not only exposed the vulnerability within the United States public health infrastructure, but also how underlying chronic conditions and lack of access to healthcare put too many Americans at great risk. Across the globe, we see billions of people without access to vaccines and medical care, which means that SARS-CoV-2, its variants, and other infectious disease threats will continue to threaten us all. Experts had warned for years that a pandemic of this scale was coming, and we must expect additional diseases to emerge. We need to ask ourselves, are we ready? We must have a strong infrastructure that can identify and detect outbreaks at their source and take quick action before they take hold. Over the last 12 years, the United States has faced 4 significant emerging infectious disease threats: the H1N1 influenza pandemic, Ebola, Zika, and now COVID-19. We are also confronting an overdose epidemic, a drug overdose epidemic, with nearly 500,000 people dying from an opioid-related overdose between 1999 and 2019. The increase continued in 2020 and appears to have accelerated during the COVID-19 pandemic. These experiences show that public health emergencies are here to stay. Each of these threats demanded a rapid and unique response, but none resulted in the sustained public health improvements we need. Long-term investments in public health infrastructure, flexible infrastructure, will save lives and avert economic losses caused by public health emergencies and chronic public health problems. The fiscal year 2022 request makes initial investments to continue public health data monetization, build the public health workforce, enhance global health security, and strengthen our immunization infrastructure. In addition, we are requesting funds to help states and communities be climate ready and prepared to confront new health risks, such as those associated with vector-borne diseases. The fiscal year 2022 request also makes specific investments in programs that work to improve health equity, such as maternal mortality review committees. With new resources outlined in this request, CDC will also significantly expand efforts to address the social determinants of health. Proposed increases will address public health problems that have been exacerbated by the pandemic, such as opioids, injuries, and violence, HIV, and sexually transmitted infections. We at CDC are grateful for your support and look forward to working together to build a sustainable, resilient public health system that can respond effectively to emerging threats and meet the public health needs of every American. We will work tirelessly to ensure the health of this nation and the world. Thank you, Dr. Schuchat, and I very much look forward to your questions.
Thank you very much, Dr. Walensky. I also might add, before I get to my question, that it is when you spoke about the work done by CDC with the with vaccine, et cetera. I also want to mention, because yesterday we had the NIH who appeared before the committee with for their budget hearing, and it was remarkable that the achievements that you have made were, this was possible not only by targeted investments in COVID research, but I believe also, and I think the subcommittee agreed yesterday on a bipartisan basis, by the annual and the sustained investments in biomedical research made by this committee over the years, which was over $650 million in basic research on coronavirus that helped us to be able to move as rapidly as we were able to. And again, thank you for your outstanding work in this area. I have a question for you, Dr. Walensky, and also ask Dr. Schuchat to respond to it. It's clear to me that our nation's public health agencies cannot go from crisis to complacency to crisis. We can't think about public health agencies just during the crisis, about thinking about the infrastructure of our public health system. In your opinion, after more of what COVID-related lessons and response efforts need to be sustained post-pandemic that public health agencies, including CDC, as well as state and local health agencies, are better positioned every day to support the health of our communities? When we did our hearing, our health partners testified about core needs of public health data, workforce, laboratory that are not specific to one disease or activity. Do you agree?
Thank you, Chairwoman DeLauro. First, let me say congratulations to you and the state of Connecticut for all of your extraordinary work in getting vaccines rolled out. I've been a beacon example, so thank you to you and the state. That's been extraordinary. Maybe I'll just jump off of where you started with, which is the NIH, and just comment that what we're looking for in the CDC budget is something very similar to what has occurred with NIH, and that is long-term, longitudinal, sustainable increases. And maybe I'll just highlight that there's evidence that once a scientific study has been published, that by the time it gets to the community, the core community in the rural South, in the urban settings, that it can take up to 17 years before it gets from the scientific data to a guidance, to training doctors, to reaching people in hospitals, to then reaching people in the core community. It can take that long, and that is the work of what public health can do. And that is why we need the sustainable resources. I think the buckets that you just described are exactly where we need to be and what we've learned, where we were fragile in the COVID-19 pandemic. Our workforce. We need an upskilled, trained workforce that is diverse both in discipline and in background, coming from the communities that they are going to serve. We know that over the last decade, when we've had all of these infectious threats, that we've lost over 60,000 public health jobs. We also know that about a quarter of our public health workforce is eligible to retire. So we now need a data-savvy, skilled workforce that works at state health departments, local health departments, and in the communities, community health workers to reach the people that they serve. We need to bolster our public health labs. When we started in this administration, we were doing less than 3,000 samples of genomic sequencing a week. We're now up to 35,000 samples a week. We didn't have the infrastructure in the lab to be able to bolster that. And then finally, as you know, the data monetization and the need, you mentioned the facts, is that the personal data entry, the need to bolster our data to make sure it's interoperable across different health departments, across different states, and up to the CDC.
Dr. Schuchat, would you like to please comment? Thank you.
Thank you so much, and thank you for your kind remarks. Just to, of course, agree with Dr. Walensky about the priorities, I would just add that we live in a global world and that COVID has taught us that a threat anywhere is a threat everywhere. We were not as prepared as we thought we were here, and we know that every nation needs that capacity to prevent, detect, and respond adequately, and we need systems that can surge rapidly, and we need to work together on that. I regret that I'll be 33 years at CDC leaving with a public health infrastructure that is not stronger than when I got here. When I look at the NIH and the enormous improvements in biomedical research capacity that we've seen, I wish that we'd seen the same kind of strengthening of our public health capacity, because I think we have all seen that regardless of the fantastic scientific breakthroughs, if we don't have that frontline workforce and we don't have a nimble and resilient system, if we don't have data systems that surged and are faster than the threats we're facing, that we're all vulnerable. So I hope that the incredible investments in COVID will be extended for the other threats that are out there.
Just a quick follow-up. We included in the emergency supplemental last year expediting the modernization, the data modernization initiative. Just very quickly, can you give us, any kind of a progress update on the multi-year initiative? Go ahead, Dr. Walensky.
Sure. This has been something that we knew we needed to address early on, and we are now working across. So, for example, the electronic health records that we were able to do in COVID, we were able to bridge test results with electronic health records from Cerner and Epic to be able to gather more data in a HIPAA-compliant way. So all of these systems have been bolstered very much. We've had to move quickly through the COVID-19 pandemic, but we really do need to work with our health centers, our public health workforce, bioinformatics and information through the private sector, and all of that work is actively ongoing.
Thank you. My time has expired. So, Congressman Harris, please. Sorry, I went over time. Go for it, Dr. Harris.
Thank you very much. And one thing that's important is that the public have trust that science is behind decisions made by CDC and public officials. So the first question I'm going to get out of the way quickly is that Dr. Walensky, are you and Dr. Schuchat in the same room?
We are.
You are, and neither of you have masks on. So what I'm going to ask you is, if we were conducting this hearing in a House committee room, we would all have to wear masks, whether we were vaccinated or not, because that's the ruling of the Speaker. In fact, in the House chamber, we have to wear masks. I have a very simple question. Did the Speaker or the attending physician of the House consult with you or anyone else at CDC before coming up with that policy? A policy that, by the way, results in a fine of up to $2,500 for someone who's not wearing a mask who's been vaccinated. Did they consult with you?
We put our mask guidance out about 2 weeks ago that spoke to the science about individual risks, and in fact, those decisions have to be made locally. So our guidance was data-informed, scientific.
Did they consult with you before coming up with the House policy?
We've been in contact with both the Capitol physician as well as the Speaker's office.
So they consulted with you about this policy?
There's been, we've been.
That's a simple question. Did they, before they came up with the policy, which is a new policy now that 100% of people have to be vaccinated before anybody takes a mask off, did they consult with you about science behind that policy?
The science that we put in our guidance is related to the science of individual risk, and then the decisions have to be made at the local level with data that we do not.
Dr. Walensky, that is not responsive, and I'm actually puzzled by why you're not. It's a simple yes or no answer. Did they consult with you? This is why America doesn't trust public health officials. This is why America doesn't trust elected officials, because I can't get a straight answer about whether the Speaker of the House and attending physician consulted about the latest change in policy, which is that 100% of members and staff have to be vaccinated before anyone takes their mask off. Let me turn to the problem with schools. Is it true that the teachers' unions helped drive the CDC policy on reopening schools?
As a matter of practice within the CDC, we engage with many partner organizations related to any guidance that we put out. So
Okay, so it's just coincidence that the wording of the guidance pretty closely mirrors some of the discovered communications between the teachers union and CDC.
we engage with many partners. I spoke to teachers, I spoke to parents, I spoke to many people before that guidance came out. And what became clear in some of those discussions that there was a piece missing. The teachers were asking for what happens if we have a teacher who's immunosuppressed. How do we act if we have a teacher who's immunosuppressed or a family member of that teacher who's immunosuppressed? That piece was missing from our original document. And with the feedback, we were able to include science-based recommendations.
Okay. Now, the other thing that, again, and I appreciate we discussed at some length yesterday on the telephone, the need for people who've had prior infections to be vaccinated with 2 vaccines, if they're receiving Pfizer or Moderna, despite the evidence that first of all, that there is a good T-cell response following natural infection, whether symptomatic or asymptomatic. That information has been out there for months. And a recent study by the Penn Institute of Immunology indicated that there is a very robust response after only 1 additional vaccine. So given that these are still experimental vaccines, these are under emergency use authorization, would it be reasonable to begin looking at saying that people with vaccine who have had disease should either have tests for antibodies or T cells, or should only get one vaccine if they're in a 2-vaccine regimen?
Dr. Harris, I think you bring up one of the things that's going to be the holy grail of this, and that is what are the correlates of protection, both in the T cells as well as the B cells. As we had the pleasure of discussing the other day, we don't have great correlates of protection in either of these. And in fact, we can easily measure antibody response. We don't even have a good measurement of T cell response right now. When we get those measurements that we can use in a large scale public health sort of way.
So the Oxford, and I only have a few seconds left, the Oxford Immunotech test, which unfortunately FDA has put on the back shelf for evaluating for EUA, but is licensed in England, is not a good test?
I'm saying it's not applicable that we can use now at a public health way to make a decision about whether somebody who's sitting in front of us should get vaccinated or not.
Sure. Thank you. I yield back.
Thank you. I'd just like to make a comment. I'm looking at a document that is dated May 13th, 2021. And this was a major speech made by the American Federation of Teachers President Randy Weingarten, where she says, there is no doubt schools must be open in person 5 days a week with the space and facilities to do so. We know that's how kids learn best, and that prolonged isolation is harmful. Educators have yearned to be back in school with their students. They only ask for 2 things: a safe workplace during this pandemic and the resources they and their students need to succeed. With that, I'm going to recognize Congresswoman Lee, but I'm going to step away for a moment to pose a couple of questions to Secretary Mayorkas in the Homeland Security hearing, and Congresswoman Lee will take over the gavel while I am gone. I should be back in short order. So, Congresswoman Lee, you are recognized.
Thank you very much, Madam Chair, and thank you to Dr. Walensky for your testimony, and also for your leadership in declaring that racism is a public health threat. And also to Dr. Shukik, thank you so much for your 30 years of service and your commitment to public health. We're going to miss you, but you've really made your mark, so thank you so much. Let me ask Dr. Walensky with regard to the whole issue of structural racism in public health. It's undeniable, so again, thank you for the declaration. We've got to work together to ensure that our healthcare systems work to confront and dismantle the racist systems and practices that perpetuate racial disparities. And so Congresswoman Ayanna Pressley, Senator Warren, and myself, we introduced the Anti-Racism in Public Health Act, which calls for the development of a National Center for Anti-Racism at the Centers for Disease Control and Prevention, and also a law enforcement violence prevention within the National Center for Injury Prevention and Control at the CDC, in coordination with the Department of Justice. Now, the president has included $100 million for CDC to start a new community-based violence prevention or violence intervention initiative. And so in what other ways are you going to ensure the interagency and interdepartmental collaborations and accountability to really begin to address and dismantle racism in public health? And is this 100 million appropriate to use to begin to establish some of these programs that we have laid out in our legislation?
Thank you so much, Congressman Lee, and really to you for your extraordinary leadership in this area. As I think you know, I have history in my work in HIV, which is where this interest for me has started, and I know you share that interest as well. As you know, about a month ago, we declared here at CDC racism as a serious public health threat. Through COVID-19, we very much saw that 0.8 years of life lost for people who are white, 1.7 years of life lost for people who are Hispanic, and 2.9 years of life lost for people who are Black in this country due to COVID-19. Truly extraordinary years of life lost, and that is, opened the door for us to be able to do that for everybody else, to see what you and I have been seeing for years, that health is different for people of color in this country. One of the things I charged my agency with, my center directors with, when we made this declaration, is to say, yes, we've documented the problem in all sorts of different kinds of screening mechanisms and all sorts of different care. We've documented that these are disparities in care. I want to now do something about it. So I've asked each of my agency center directors to plan an intervention for the next year, a measurable intervention that will show impact in how we can improve health in people of color in this country. And among the areas where we are going to be using these resources is deep in these communities. It's among the reasons that we need community workers to understand the impact of what's happening in those communities and understand how we can reach them. And I really look forward to seeing what our center directors are planning and what they find.
Thank you. And one thing I'm working on, Dr. Walensky, is the issue of the lack of Black men in medicine and behavioral health professionals. And so anti-racism strategies have got to be integrated into all areas where we see shortages of people of color. And so I'm wondering, as you move forward on this, how are you looking at putting these strategies together across the board everywhere within your authority?
One of the things I think that's so important is that our workforce be diverse, both in their expertise as well as in their background and the communities they serve. They need to come from the communities they serve. I had the great pleasure of being in rural Georgia last week talking to a rural community, and I said, how are you doing in vaccination? And they said, well, it didn't work when they sent in the National Guard. They trust the local firefighter. Right? These communities trust the people who have been in the communities, from the communities. I've seen that in working with community health workers in my own HIV work back in Boston. They trust the people from the communities. It has to be at every single level of expertise.
Okay, thank you. And finally, I have a few seconds left. Let me just ask you, as it relates to sterile syringes. We know it's the most effective intervention to prevent the spread of infectious diseases. And so how are the syringe service programs working, and how are we encouraging organizations, healthcare entities to use this program, syringe service programs?
The opioid crisis is a real challenge. It had been a challenge before the pandemic. It continues to be a challenge, both and in fact, it was exacerbated by the pandemic, both in terms of infectious threats that are transmitted through injection use. And so, yes, we are working closely to embrace the sterile syringes under the context of the law and what we're able to do, and we're really looking forward to moving forward with these.
Thank you very much. I guess our chair, I'll yield back to you now, Chairwoman Delara. You made it back.
Congresswoman Herrera Butler.
Thank you, Madam Chair, and thank you both for being here and for your service. I think my question for you is for you, Ms. Dr. Walensky, and I think part of my challenge is it's all based around how we're treating children in this pandemic. there's a large amount of discussion around school reopening, but I hear from parents in my district whose children are being forced to quarantine for long periods of time beyond CDC guidance, which ultimately interrupts their learning. And in some cases, a medical provider is not allowed to clear a child to return to school. And throughout your guidance for school reopening, the CDC has encouraged students and parents to talk to their healthcare providers, but it seems like their opinions are being overlooked, which is hugely disappointing. So on one hand, I want to make sure that you're communicating, and I wanted to ask what you're doing to communicate down through the levels to the local level that can provide some of this guidance. But then I think the broader observation that I have is I do think we're getting so many mixed messages. It's very difficult to have one source of information. You know, I saw a story in the New York Times from a week or two ago that said that CDC's benchmark for outdoor transmission was said it was about 10%, which if you dig down on the science on that, it's really leading doctors will say it's actually less than 1%. So to say 10%, it's not inaccurate. It's just really imprecise. And so when you have this kind of muddle of information flowing around, it causes some real challenges on how do we provide leadership in our communities with regard to what to do. That brings me to the next point, which is masking in children. I brought this up yesterday. I think children have disproportionately borne the isolation burden throughout this whole pandemic, whether it's learning loss through school, interaction with one another, especially children in the younger grades who are learning to talk, who are learning to interact, whose social emotional interaction is really what's at stake. You know, I saw some remarks from I'm not going to say his last name right, so I'm not going to try, a doctor from Stanford, but I can provide you his name. I just don't want to butcher it. Citing studies from Sweden and the WHO, who recommended in the Wall Street Journal that we avoid masking kids up until at least age 11 because they're at low risk for infection, and their very real hazard is stunting their development. And yet our only recommendation at this point is young kids, you're going to have to continue to mask as we're lifting this burden on everyone else. We're going to make you do it. We're going to make you do it outside where there isn't a single documented infection instance anywhere in the world from that casual outdoor interaction. So I wanted you to speak to, because science is our base, right? That's what you said. That's what the chair said. That I believe that. But the science doesn't show that children are at high risk. And CDC study from last July shows that they're not at high risk for spreading it either when we're talking about, about 2 to 7, 8, 9, right? So why are we making the kids bear this burden?
Thank you, Congressman. First, maybe I will acknowledge two important things. One, I have 3 kids myself. One has been home all year. I understand the challenge. I deeply understand the challenge. And maybe the second is the complexity of managing guidance and information and providing it to the public when it is changing and when it is evolving and when we are learning so much so quickly, and how we are able to evolve our guidance in the context of that. And I think you're highlighting something that's really important. This is complex. And as we change things that we knew a year ago are different now because we have much more information and they continue to evolve. I have always said schools should be the last place to close and the first place to open. And I very much still agree with that. I very much want those to be safe places. My own kids were home from camp last summer, and I want camps to be open this summer. All of our guidance has highlighted it's better to be outside than inside. And what I really want in our camp guidance, and we're working through revising that guidance in the context of vaccination for 12 to 15-year-olds, my whole goal is to make sure that camps can remain open and that outbreaks don't occur.
Can I jump in on there just because my time's running low, and I appreciate that. Based on the science, children 0 to 4 are less than, I think it's 1% or 1.3% of all infections. And so I guess part of me is saying, I get it, 12 and up, you can get a vaccination, but you can't vaccinate the younger kids, yet they're at low risk for getting it. They're at even lower risk for hospitalization. They're at low risk for spreading it. So why are we making them mask? Because the science doesn't support that.
There are still transmissions associated with young children. They have been vectors of transmission for older people.
What studies? That's the thing I need to know. Maybe you can provide that because my time is up.
I'd be happy to
Can
do
you
that.
provide the studies for that? Because that's
Yeah,
not readily available. Thank
absolutely.
you.
Congressman Pocan.
Thank you very much, Madam Chair, and thank you both for being with us. First, I just want to say, I'm very happy with the increase that you have. You've outlined many ways you're going to spend it. I guess my only regret, and this might be Barbara Lee's as well, is that the Pentagon increased budget alone is more than 50% than your total budget. For perspective, I think that's important for people to understand, given the biggest threat to this nation in the last year was COVID-19. Having said that, let me ask a couple questions. First, about contact tracing. Is this a good time to really be very specific in our contact tracing efforts? I know it was hard at moments last year to keep up. I think at one point we were doing 1 of every 5 people is the best we could do in the state of Wisconsin. But now that you've got far fewer people, is this something worth intensifying the efforts on to really help further eradicate its spread?
Thank you, Contact tracing has always been a strategy for containment. We've used it in measles when we have fewer cases. And in fact, it is hard to do contact tracing when you're in a mitigation strategy with hundreds of thousands of cases, as you exactly note. So yes, I think now is a good time with fewer cases. We're able to do so. We're able to isolate. But I think one of the bigger things to mention is, who are those contact tracers? They are the community health workers. They are the people who are on the ground, the infrastructure we never had that we couldn't deploy to do the contact tracing to begin with. And that's what a sustainable public health infrastructure will be able to do. They'll be able to be in the community working on hypertension, childhood vaccinations, diabetes control, and then pivot quickly when you have an emerging threat. So I believe our contact tracers should not only serve as contact tracers now, but as vaccine navigators. They know their community and really to promote both quarantine of people who are potential contacts, but then vaccination.
I don't want to put words into your mouth, but I would like to be able to pass on this information. So this would be a good time to make sure that we are thoroughly doing contact tracing with the limited cases that we will not have.
And I would emphasize contact tracing with vaccination, because those who are have to quarantine are likely those who are not vaccinated.
Gotcha. Thank you very much. Second question is, I know that when you put out the new guidelines, it was a lot of new guidelines at once for everybody. And last night, Secretary Walsh was in town, so I was out doing a few things in the community. And based on your guidelines, I haven't been doing many things I wasn't supposed to in my district previously. I have, but it seems like the change has been very. A lot of people are doing behavior without masks and things, which is in many ways okay. Are there things that if you are vaccinated that we should still not be doing right now? And if you're in a mixed crowd that we should not be doing right now?
Thank you. The guidance that we put out for fully vaccinated people was really intended at the individual level. And I think what we really need to understand is that the policies have to be locally driven. What we know is that there are counties that still have less than 20% of people vaccinated and still greater than 100 per 100,000 cases of disease every 7 days. And so this was the start, because in fact, we needed people to recognize that this was important information, science-based information, to make those local policies. But the heterogeneity of both vaccine rollout and cases, I think, really needs to be taken into account here.
So for example, indoor situation, but mixed. If you know at least a quarter of the people aren't vaccinated and you are within 2 feet of people in the size of the room, should you be wearing a mask?
I would defer to the local policy, but I would say if you need to make that decision yourself and you're vaccinated and you are not immunocompromised, it's not you that is at risk, it's the unvaccinated cohort.
Gotcha. And then the last question in the minutes left about sending vaccines abroad. You mentioned in your initial comments. I personally am trying not to do any international travel this year just because I think the rest of the world is not as far as we are in vaccines. But what should the U.S. be doing more to make sure, because we're never really going to be in the place we want to until we get people vaccinated across the world? What more should we be doing?
I think Dr. Shukit actually already noted a disease anywhere now is threat to us here. And so we need to be assisting. We've already put $4 billion into COVAX, $2 billion that's already been given, and another $2 billion that's going to be 80 million doses of vaccine that we're hoping to get out before the end of June. And we at CDC are going to be providing global support, technical support, how we do massive immunization campaigns, how we do vaccine safety, and we will be providing all that support.
Great. And just in the remaining 9 seconds, thank you. I know you've all put a lot of extra time in. It's been a pretty tremendous time in our history. Just want to say thank you. And I yield back, Madam Chair.
Thank you so much.
Congressman Klein.
Thank you, Madam Chair. Appreciate you having this hearing today. I want to thank our witnesses and ask Director Walensky, in encouraging vaccinations, and I encourage people to get vaccinated, you mentioned the local specific, that we need to be specific for each locality, each individual. But suffice it to say that your recommendations include the idea that if you are vaccinated, not only do you run a reduced risk of contracting COVID, but you have a reduced risk of transmitting COVID. Is that accurate?
That is what emerging science is telling us, yes.
Okay. So circling back to the ranking member's questioning, were you in contact with the attending physician, Dr. Monahan, as he developed this most recent policy announced by the speaker where 100% vaccination was encouraged? Were you in contact with the attending physician?
We've been a resource for the Capitol physician throughout this pandemic. I know our offices has been in contact with him. I can't tell you exactly the timing of that in terms of when the last discussion was versus when the guidelines for the House came forward.
Okay, were you in contact with his office as he developed recommendations for the Senate? Because the physician also provided a recommendation to the senators as well. Are you aware of that?
Congressman, my reply to that would be the same. I know our office has been in contact, but I just couldn't tell you when our office was directly in contact with him and when his decisions for either the House or Senate occurred.
And would it surprise you to learn that the attending physician issued a recommendation to the Senate that was substantially different than the recommendation to the House, and that the Senate was encouraged to proceed with normal business without masks being required, social distancing respected, but that 100% vaccination was not required in recommendations from the attending physician's office to the Senate, but in the House, it is somehow being mandated. Does that surprise you?
Congressman, one of the things we've just mentioned is how complex these decisions are in the case of evolving science. Of course, the Capitol physician has much more information than I do about both the vaccination rates in each the House and the Senate, as well as the medical records of people, as well as the average age and immunity durability. So I think he would be best equipped to make those decisions.
Well, the senators on average are older. The average age of the senators is higher. And the science of the virus is not different in the Senate chamber than it is in the House chamber, correct?
I just don't know the immunization rates of each of the House and Senate, and he would be equipped with that information that I don't have.
Is it your opinion that that American society should be 100% vaccinated before we open back up?
As I mentioned, I think that these have to be locally driven, both based on vaccination as well as based on background rate of disease.
That's a pretty good softball for you. Do you have to be 100% vaccinated to open back up and stop wearing masks?
No, I don't believe so.
Okay, thank you. Let me ask you about the business community. The livelihoods of many businesses in my district have been threatened over the last year as they work to adjust to the changing environment during COVID. As more has been discovered over the last year, guidance has changed as well. Federal Reserve study found that the pandemic resulted in the permanent closure of roughly 200,000 U.S. businesses. What will you do to empower states to determine how best to govern so that overly burdensome recommendations and regulations from the federal government do not cause further harm?
we have been putting forward, first of all, we're working to get people vaccinated, because I think, as we have seen, when people get vaccinated, disease rates in their local areas come down, and that is the ticket out of this, in my mind. When people get vaccinated, we are working really hard with all jurisdictions, with all communities at the state, the local level, to get people vaccinated, to ensure confidence, to provide the best information possible, so that people feel empowered to make these decisions, that they're the right decisions coming from trusted messengers in those communities. And so we're working to do that at the public health level. And then we're providing the guidance that can lead to informed decisions in communities with local jurisdictions, with governors. I spoke to the governors yesterday to make sure that our guidance is applied to the in a safe manner at the local level.
Thank you. I yield back.
I'd
like to recognize Congresswoman Clark, but for one moment, I'm going to again hand the gavel to Congresswoman Lee, so I can just see it did not work the last time of getting to Homeland Security, and I will get there and get right back. So Congressman Clark, you are recognized. Congressman Lee, take the gavel.
Thank you so much, Chairwomen. And thank you both for joining us, and just the deep gratitude of a nation for the work of the CDC and the response to this pandemic. Dr. Walensky, you and I have talked about the value of public service, the importance of treating public health jobs as we would a career at DOJ or Defense. Are there programs or incentives that the CDC would like this committee to prioritize that would address the needs of our public health workforce? And in particular, how can we work with the CDC and state and local level to build a more diverse public health workforce?
Thank you very much, Congressman Clark. I think one of the things that's really important here is to make sure that the compensation is competitive with the private sector in our public health jobs. As I talk to the state health officials, they would tell me they can't hire an MD in a state public health. The compensation wasn't competitive. Somebody who came out of medical training and medical school with, on average, $200,000 worth of debt was not going to enter the public health workforce because they didn't have salaries that are competitive. As we're working on expanding our disease detective EIS program, one of the things we're really looking forward to is hoping to do loan repayment programs. And across our workforce of our training, loan repayment programs would really go a long way, so that people could enter into the public health, which obviously pays less than the private sector. Many of the training programs that we would put forward to be tuition free, to be accessible to people who have had less resources.
Great, thank you for that. And anything specific around your plans and strategies for increasing diversity in your workforce?
We're reaching people where they are. We're working to go to historically Black universities. We're working in communities to try and bolster people within the communities. We have the potential now, as we're scaling up our workforce within public health, that we've had to do by necessity through this pandemic, to retain them. These are people who are interested in public health. They've demonstrated, they've volunteered to help, and now is the time to skill them up, to retain them, and to make sure that they can continue the important work that they've been doing, to continue the outreach that they've already made, to maintain that network. And that, I think, is really going to be key for our next step forward.
And just really quickly, if an employer made a decision around masks based on two different groups, one that had a 96% vaccination rate, one that had a 77% vaccination rate, would you think that was a fair way and aligned with the science to make a decision around masks at the workplace?
Most definitely. Almost every morning I look at a map of vaccination rates across this country by county.
Thank you. Dr. Schuchat, I was wondering if you could tell me a little bit about the gun violence research that was first funding in 20 years in the FY20 budget, And I wondered if you can tell me what you were learning in our research on firearm injury and mortality prevention. And we just so appreciate you treating this as a public health crisis that it is, and any updates and strategies and interventions that have emerged from the research that you can share.
Thanks so much for that question, Congresswoman Clark, and for the congressional resources that we first got in 2020. Our call for proposals for firearm safety opened a flood of applications, and we were really pleased to be able to fund several that were focused on the gaps that the National Academy of Medicine had identified. The scientific research that we're supporting is helping us understand firearm-related injury across different types of incidents, different types of populations, and different settings. We had 18 funded sites in that research. They're looking at firearm behaviors and co-occurring mental health and behavioral risks among youth. They're looking at individual and neighborhood level risks for firearm-related violence so that communities can design tailored interventions. And they're studying a clinical screening tool to assess youth risk for future firearm violence. These are really important projects that span the nation, but I can say we had so many more applications than we were able to fund. So the ability to scale that up is going to be precious. The other aspect of the resources that we received helped us strengthen the data gathering on the surveillance, just so we would know who was getting injured by firearms and where these events were occurring, when they were occurring, so that we could understand trends and risk factors. So I think it's a really important, precious area for us to continue.
Thank you so much. I see my time has expired. I yield back, Chairwoman Lee.
Thank you very much. Now I will yield to Representative Frankel.
Good morning, and thank you both doctors for all your good work. And not to monotonize this discussion on members wearing masks, but I would, Madam Chair, I would respectfully suggest that our colleagues who do not want to wear masks, who we've heard from today, ask their colleagues who have not got vaccinated to get the vaccine. Because, I think I speak for most Americans who have been vaccinated, and we don't want to wear masks, but we do not want to be sitting in small areas or with people who are refusing, who know better, who are refusing to get vaccinated. So my next question, Doctor, either of you can answer this, is what is expected when we're going to need boosters for our vaccinations?
Thank you for that question, Congresswoman, and congratulations on your grandbaby, who I think was was pending as we last spoke.
Yes, he's here. Thank goodness. Something came out of the pandemic.
On the topic of boosters, I think that it's really important for us to understand several things. First, if you've received 2 doses of vaccine or you're completely vaccinated, right now you don't need a booster. You're protected, or at least the data that we understand now for the general population implies that you do not need a booster right now. I think all of us recognize that we don't want to be back to where we were again. And so we would like to study this. We are studying when we might need a booster. And in fact, that gets back to what are the true correlates of protection. We do know that antibody levels over time, we've seen they wane. And so the question is, when they wane, are these people still protected? What do these quantitative numbers mean with regard to protection? We also know, importantly, that we vaccinated first our most vulnerable. We vaccinated people who are in long-term care facilities. We vaccinated our elderly. We vaccinated people who might not have had the most robust immune response to start. And so we are looking at the timing of when boosters might be needed. Will it be 6 to 9 months? Will it be 9 to 12 or 1 to 2 years? We've seen data from SARS, that the SARS-1, that have demonstrated reinfections after 2 or 3 years. That's after natural infection. And so I think the most important thing is we certainly want to be ready. And so that's where we are right now.
That's good. And do you expect, though, that the booster, the next shots, we're going to be able to get them like like with the flu shots, not having to go to mass sites and things like that?
I think one of the things that's really important to recognize here is we don't have an adult immunization structure in this country. We haven't. We have a childhood immunization structure in this country, but we do not have one for adults. We don't have a mechanism to do this right now. And among the reasons for the funding is to develop and bolster an adult immunization structure in this country for flu shots, for COVID vaccines if we need them again. That would be the vision for Shingrix, for all the other, for tetanus when we need tetanus updates, for all of the things. We don't have that mechanism right now.
Well, thank you. That's a good idea, because our rollout in Florida of the vaccines was chaotic. I said it was like the Hunger Games here. So I mean, it was frightening. I think part of our population that really suffered were the elderly, and just interested in whether you're doing any work to address, how we handle these kinds of situations with our elderly population. There was so much isolation and depression.
I think you're noting the elderly specifically, and I totally agree. The isolation here had been so challenging, and in long-term care facilities, so devastating to watch. But I think you're raising a larger issue too, which is the mental health of this nation has suffered. And so we are doing a lot of work in collaboration with SAMHSA to evaluate mental health related issues, to look at issues related to suicide, to do more surveillance, and to do outreach with interventions that are data driven, that have toolkits provided by the CDC for how we can do outreach in these communities with community workers, to really do evidence-based science in mental health across the age spectrum.
And real quick, talking about toolkits, how about in terms of ideas for communities on how to increase vaccination rates? Is there a place that our health departments can go to get different ideas or strategies?
Yeah, thank you for that. We have an extraordinary number of resources. We have vaccine confidence consults. You can call the CDC and get a vaccine confidence consult. We have through HHS the We Can Do This campaign. It's 5,000 community core. So if you have a group that NASCAR speaks to, you can go get your vaccine and then take a ride around the Talladega track. So there's lots of different ways to engage with this community core through the wecandothis.gov. I would really encourage your state departments to engage these community core organizations, be it NASCAR, NFL, country music, or infectious disease societies of America. Faith-based organizations can really help do the outreach so that people are talking to people they trust.
Thank you very much. Yield back, Madam Chair.
Let me thank my colleague, Congresswoman Lee. Mission accomplished. And with that, let me recognize Congresswoman Bustos.
All right, thank you, Madam Chair. And Dr. Walensky, thank you so much for taking time earlier in the week to chat. I'm going to talk with you a little bit as an extension to what you just shared with Congresswoman Frankel about new ways and innovative ways to reach out to people, specific in this case to rural America. I talked with Dr. Fauci about this yesterday at our hearing. He was going to take the questions that I was asking about reaching rural residents and try to come up with some new ideas, but want to talk specifically about the disparity between those who live in rural counties compared with those who live in more urban counties. We know by the numbers that CDC has released that it's less than 40% of residents in rural counties who have received at least one dose, compared with just about 46% in urban counties. And so it is, I want to hear your thoughts about vaccine hesitancy, other issues that are specific to rural counties. If I may throw out an example, in the congressional district that I serve here in Northwestern Illinois, we have one county, which is a couple counties south of where I'm talking with you right now. It's along the Mississippi River. The entire county has 6,700 residents. And early in for people to sign up for the vaccine, they just had a couple phone lines. Broadband is spotty at best. Their volunteer corps, as far as getting people out to help, were very, very senior themselves and were concerned about getting COVID themselves. So that was all brought to a halt. They were registering people. There was no online portal to register. It was all handwriting, paper and pencil. And so now with the announcement that just came out earlier today, where we have half of the adult population that is vaccinated in this county, only 19% overall is vaccinated. And so just these great big disparities. So I'm just wondering, Dr. Walensky, on top of what you just talked about, and I'm very curious, like, can I get a Chicago Bears player to come to Henderson County? I mean, I'm just kind of wondering how that might work. But what steps is the CDC taking to increase these vaccination rates in rural areas, and specifically also how we can address vaccine hesitancy? And maybe even really talk through like these celebrities, because maybe that would be a way to have this work, and wondering if we could get some folks in my neck of the woods to help out.
Thank you for that question and for highlighting data that we've discussed about these discrepancies in vaccine rates really through the end of April. Another piece you didn't actually raise is the discrepancies in telehealth, right? Rural counties would be so helpful to have telehealth in, and yet we saw in a previous MMWR that telehealth wasn't reaching for exactly the comments you said: broadband, telephone, decreased access. I think it speaks to the fact that we don't have community workers in these communities that have had a long-term public health infrastructure in these communities to do the work of public health. We don't have a public health department that is sustained, that's been viable, that's been well tended to, that has competitive salaries, respected positions, and community workers in those communities to do the work that you're talking about. And that is exactly what we've had resources that have gone out that are specifically line itemed for rural areas, because we've recognized that deficit through the context of COVID. We've had community-based organizations specifically outlined for rural areas through the context of COVID. And what we're asking for, not just to have it for the context of COVID, but now you're going to find them. You're going to find these people who are devoted to this community work. We need to make sure that they're trained. We need to skill them up. They need to be able to interact with the data systems. You don't have data systems there for people. You're doing it by hand, by paper and pencil. That is not a way to do public health in this country in 2021, never mind for what we need to reach for in 2030. In terms of what we're doing now, you and I discussed, I was in rural Georgia, and it was really incredible to talk to the people who are doing this work, who are going door to door, the elderly people, as you note, and who are hearing the National Guard didn't work. What did we need to do? We needed to be at the change of shift at 4 a.m. and have people trip over us and say, can you get your vaccine now? That's the kind of grassroots efforts that we're moving forward with now, that we have these confidence consults that people can call the community core. I'm a Patriots fan, I'm sorry to say, but I bet the Bears might might do something to facilitate. I do think when you call these wecandothis.gov, you'll get a wealth of resources. These people want to help.
Good to know. Dr. Walensky, again, thank you to you and your team for all you're doing to help our country get past this pandemic. Grateful to you. With that, Madam Chair, I yield back.
I don't think you need to apologize for being a Patriots fan.
Now we get to the real core of the issues here.
Patriots.
But my hope is that you're a Yankee fan, so it doesn't have to be a Red Sox fan here, right, Catherine? Anyway, Congressman Harder. Congressman Harder.
I don't know if I want to get myself in the middle of this, but thank you so much, Chair DeLaura, for hosting this hearing, and thank you so much to the witnesses for taking their time, and a special thanks to Dr. Schuchat for your decades of service. One of the things that I really wanted to focus on is how this pandemic has highlighted some of the gaps in our public health system. I think one of the things that has become abundantly clear to me is just how critical a strong, well-funded public health workforce is to care for folks across the country, especially in rural districts like mine, where capacity, especially healthcare capacity, is already thin. I've seen the beginning of some grant announcements out of the CDC that's going to help fund some of the programs outlined in the American Rescue Plan, specifically the $7 billion investment to hire and train public health workers. Dr. Walensky, could you describe the rollout of the funding for these public health hiring and training programs, and especially how the CDC will support these positions on an ongoing basis after the rescue funds expire?
Thank you for that, Congressman. You know, we just put out the first tranche of $7.4 billion. Really, 4.4 is intended to help scale up where we are now to get us out of this pandemic, to do the hard work of continuing testing, continuing disease diagnostics, continuing workforce for lab and genomic surveillance, and to make sure that and vaccine distribution and community workers for vaccine distribution. The other piece of it, the $3 billion, is an investment in the future to be able to take that infrastructure and to invest in the workforce that will be moving forward. But I think the most important thing you highlight is that these are not one-time investments. One-time investments will not fix the problem that led to this pandemic of COVID-19 and our inability to handle it. They need to be sustainable, they need to be long-standing, they need to be keeping the pace with inflation, they need to be keeping the pace with technological advancements. And so this is an investment now, but it needs to be a sustained investment over time.
How will it be a sustained investment over time? Do you expect that to be, I haven't necessarily seen that investment in the budget documents. How do you expect that to manifest itself in the discussions we're having today?
I think this is going to be a continued conversation. I think I'm going to probably see you here this time next year to demonstrate all the hard work that we've been able to do with the resources that we've had and what we still need to do in the years ahead.
Very well. Well, I look forward to working with you on that, and especially, I think making sure that rural areas that are especially strained in some of the public health capacity have like our district in the California Central Valley, some of the opportunities to get some of these grants, because I think it's very much needed. My second question is, just a little bit more broad, and to you, Dr. Shuket, I think we have a tendency to only invest in public health during times of crisis, and I think we need to be doing a lot more to improve the capacity of state and local public health departments, not even for the pandemic we're dealing with now, but to prevent others in the future. What else can we be doing to consistently and sustainably equip public health departments for future public health emergencies, and especially for the special considerations we may need for rural districts?
Yeah, every aspect of an emergency response is improved by the work that's done beforehand, the relationships that have been built, the data systems that are in place, the skill level of the staff, and the familiarity that they have with the communities and the other organizations nearby. We were not ready for this pandemic. Our data systems were very far behind, and our public health workforce was gone. Basically, the 60-some thousand jobs that were no longer filled. And so we, looking back on what has happened over the past year and over the past few decades, I think we can see that we just need to do better going forward. I want to say a few words about the public health data modernization, because I think that left us lead-footed at the beginning of this response with not really knowing what was going on and not able to keep up. And so we know, I've talked to healthcare executives who've described investments in a single hospital of $700 million versus, what our initial resources were, $50 million for the entire public health data modernization effort. I think going forward, we really need to take data and its complexity and the full ecosystem seriously, both with data scientists and with interoperable systems, migrating our systems to the cloud, strengthening what public health, local and state capacity is, and also what the CDC's is. So that's a really big, complex job. And it also relates to what Dr. Walensky was describing, where it's tough for public health at any level to be competitive with the private sector. And so we have to figure out how to attract quality individuals to work with us and have strong public-private partnerships to go even further. So I see the data hand in hand with workforce in getting us out of the state of preparedness that we were in.
Absolutely. Yeah, you can't fight what you can't find. Well, thank you so much. And with that, I yield back, Chair DeLauro.
Congresswoman Watson Coleman.
Thank you, Madam Chair. Dr. Walensky, thank you for all the work that the CDC has been doing, not only in this space as it relates to getting us through COVID and having an after COVID experience, but all the other work that you all do at the same time. And Dr. Shichat, thank you so much for your 30-some years. God bless you. You have been enormously important to all of us and our well-being, and we wish you the very best. Dr. Walensky, I'm sorry that we didn't get a chance to talk beforehand because I've got really a lot of questions. I'm just going to raise some of them. Hopefully we'll talk about them a little bit further down the road. I want to talk about the gun violence issue. I appreciate the fact that we funded research for the first time in, I guess, a very, very long time, and that is being used valuably by you all. I'm wondering with the president's new initiative where he's talking about more local interventions, what that means, what kind of, how do you see that rolling out? What are the kind of interventions that will have an impact on the kind of violence and death by guns that we see in our communities now, particularly our inner city and low-income communities?
Thank you so much for that question, Congresswoman. We're really looking forward to seeing how the investment of the initial funds from fiscal year 2020 and 2021, and as those data mature, what we learn, and then really looking forward using the template of the information that we need from the National Academy of Medicine to inform the kinds of research that is being done. Of course, that research, as you note, has to be at the local level. It has to be related to behavioral health and mental health, but importantly, it has to be at the neighborhood level and at the level, and because, you know, not every neighborhood is going to be the same. So the science that we're going to do is going to be about the who, the how, the why of firearm injury prevention, and we're going to move forward. And I really look forward to seeing how that science matures. And
So do you think we're at the beginning of that, and how long will we see the actual implementation of efforts evidenced by the research that was being done? Because we're in a very urgent crisis situation with gun violence in our communities.
I would agree with you. I will say we will need to sort of see what the science demonstrates, and then we're going to implement at an actionable level within those communities. We need to understand what the science says before we can act, and we're really looking forward to seeing how that evolves. And maybe Dr. Chukit?
And just to expand a little bit, you know, we had that first investment of the $3 million in this work, but the proposed expansion, the proposed community violence work is a larger scale. And the idea there is to take what we have shown to work through the technical packages that we've issued on violence, including on youth violence, for instance, and to scale those up, to have communities take on the ability to implement proven methods. They may involve, you know, in strengthening connectedness between kids and schools and adult mentors in the community. It will really vary community to community, but we're hoping to fund a large number of communities to really take those to scale.
And Dr. Shukit, I'm really interested in hearing some of the specifics that are going to be employed under this effort. The president also said in his skinny budget he wants to end the HIV/AIDS crisis. And one of those things I think is very important in this is the bill that I sponsored with regard to PrEP. And so what I am wondering is two things. Number one is, what do you say about the trend in HIV AIDS right now? Is it still going down? Do we see an upshot because of the pandemic or whatever? And what do you think that the resources should be applied? How are we going to ensure that they are applied across the board to all races and communities?
Thank you for that question. As you know, prior to my coming here, my career was in HIV disease and prevention. I'm an HIV doc by training. Yes, I think, right now the End the Epidemic initiative has been invested in 57 jurisdictions with the highest rates of HIV. I think that, as with many diseases that were associated with this that were occurring before this pandemic, they've been exacerbated by social isolation, by inaccess to medical care, by many things. We're looking at the investments that were made in those 57 jurisdictions, some of the lessons learned there. As I'm certain you're aware, with your interest in pre-exposure prophylaxis, it's not getting to the communities that need it necessarily, for cost reasons, for access reasons, behavioral health reasons, that places that have the highest rates of HIV actually have the lowest rates of pre-exposure prophylaxis use. And that mismatch is something we need to fix in the years ahead.
Thank you. I know my time is up, but I think that is a crisis that needs to be addressed. That is what we saw with testing for COVID. That is what we saw with contact tracing. That is what we're seeing in some respects to vaccinations, but not as much. And so that is a crisis in and of itself as it relates to poorer communities or minority communities. And I want to know specifically at some point how we're going to get at those communities. I thank you, Madam Chair. I yield back. Thank you, Doctor.
Thank you. Congresswoman Lawrence.
Thank you. Good morning. As you know, I represent Michigan and was very involved with the lead crisis in Flint. And we know that lead exposure is unfortunately prevalent across Michigan, and that includes the lasting efforts of the Flint water crisis. I'm proud to work with my colleague, Congressman Kildee, to provide funding for the Flint Lead Exposure Registry at the CDC. Dr. Walensky, I'm incredibly concerned with the high levels of lead in cities across the country, especially in the schools. When I talk to my colleagues, there are numerous schools that put the plastic bag over the drinking fountain with no research of how long did children drink from that water fountain before we put that plastic bag over it. The lasting effect. Can you speak to how the CDC will utilize the childhood lead poisoning prevention program with more targeted initiatives like the Flint Registry to combat lead poisoning in our communities, especially the impact it has on children and their developing brains?
Thank you very much, Congresswoman. One thing I think we learned from this pandemic, and this was reported in the MMWR as well, is the decrease in lead poisoning surveillance that happened because of the pandemic, the lack of access to care. I think one of the things that we will really understand as we invest in our public health infrastructure excuse me, is different communities need different things. We heard in rural communities they need broadband, but in other communities we need lead, investments in our community workers to do surveillance of lead. We're doing active surveillance, and maybe I will ask Dr. Schuchat to chime in as well.
Just to thank you for your leadership around the Flint crisis. And, the registry has been incredibly valuable for the community as a community-owned and led response. The children affected potentially could have long-term consequences, but with mobilizing wraparound services and engagement, we hope that some of that will be mitigated. We don't know how many other communities are in the same boat that Flint was in, and that is part of the focus of expanding lead surveillance through the public health systems. There are other departments that are really engaged in investments that can help reduce the exposures, the lead pipes and so forth that you mentioned. But we think that data is the first thing. We have to know what's going on to be able to target effective responses. And ideally, those are community owned the way that they were in Flint, to not just have, a distant government trying to figure out what was going on, but having those community workers who could help the families that are affected. So I share, share your sorrow about what happened and enthusiasm about the registries and the ability for us to strengthen surveillance around the country.
I will tell you, if we had a hearing on lead poisoning, many members will step up and talk about the concern they have in our communities, urban and rural. The last thing I wanted to add is to add my voice to gun violence. We know for decades there was a refusal to establish or identify gun violence as a health crisis because we were, for whatever reason, administrations did not have the wherewithal or the desire to do the data as you talked about, so that we knew that we could use the data from car crashes to implement safety belts and airbags. But we have never had the courage to see through the research so that we can begin a federally led program to address gun violence. And I just want to tell you why this is so critical. In 2020, there were 327 homicides, 1,017 non-fatal shooting in Detroit alone, a 19 and 53% increase respectively. This problem is not getting less, it's increasing. And as this obsession we have in America with guns, I can only see it getting worse. And for I'm not a mayor, but for people in Congress who are seeing these deaths so frequently, this has to be a priority. So with that, I want to yield back and say thank you so much for everything that you and the administration you're doing.
Thank you so much. We're now going to move to round two, and I think we have the time to do a 5-minute round. So thank you very much. I want to begin by, I know several of my colleagues have addressed the firearm injury, the mortality research, and I just wanted to say that so proud that this subcommittee held the first hearing in 20 years on gun violence prevention research, and we began funding for the NIH and for CDC the ability to do this research, which can take a look at what the suicide, and take a look at gun storage, and a whole variety of other areas that could help to bring relief to prevent this violence. And pleased that the president's budget proposes to double the funding to $25 million. My hope is that, and I just have a very quick question here because I want to get to a couple of others. And I guess, Dr. Schuchat, when do you believe we will have an opportunity, that you'll have an opportunity, or CDC will have the opportunity to share some results?
Yeah, the research projects are in progress, and I hope that within a year or two there'll be preliminary results from the initial investments. They're doing extraordinary work, but as you know, research can take time, and these are complex issues to fully investigate.
Right. Thank you. Thank you very, very much. Let me ask both Dr. Walensky, Dr. Schuchat. This is about cardiovascular disease in women. Heart disease, stroke continues to be a leading cause of death of women in the U.S. 2017, nearly 300,000 women died as a result of heart disease. And the research shows that women often experience different symptoms of heart attack than men, leads doctors to misdiagnose women, results in worse treatment outcomes. Critical for the CDC to support an education and an awareness campaign in all 50 states and territories on heart disease so that women can receive appropriate care. My question is to both of you. Give us an update on CDC supported activities to educate women about heart disease and cardiovascular health, and the need to create an urgency about our looking at this this issue to impact the research that needs to get done.
I'm going to let Dr. Schuchat start with that one. Thank you.
Okay, thank you.
Yeah, thanks so much for raising this issue. It's so important as a leading cause of death in women and as an under-recognized preventable problem. We know women are less likely to, they have atypical symptoms. You know, I was telling colleagues a story about my mom, you know, had neck pain playing tennis, which we thought was arthritic, and it turned out it was angina, and, you know, fortunately was you know, got surgery in time. But it's very common for women to have different symptoms, delay to be detected later because of clinician as well as bias, and to have bad outcomes because of that. So I think there can be benefit from education and communication efforts. You're familiar with our Million Hearts initiative, which is really trying to get hypertension to be well treated to prevent 1 million heart disease and stroke events, which takes public and clinician and institutional effort. And I think that the communication and education call that you raise can be done as part of that system. We're working together with the Center for Medicare and Medicaid Services in partnership on this, and education and communication campaigns are part of that. Obviously, you know, the Wear Red event that I've seen many congresswomen be part of, that can't just be a 1 day or a 1 month thing. It needs to be year round and sustained, because there's a lot of preventable deaths that we could attend to.
Thank you. That's going to be one of the issues I'd like to focus on, you know, as we move forward. I want to ask this question, and this is about the global response to COVID. We have made significant progress here, but the pandemic will not be over until there's a global success. Dr. Walensky, how is CDC working with international partners to support the global response to COVID? How is the agency planning to expand surveillance, prevention, and response to pandemic threats around the globe?
Thank you very much. A threat anywhere is a threat everywhere, right? And so we have a responsibility to not just take care of ourselves, but around the world. CDC has collaborations in 60 countries, 150 sites. And the ability to have these collaborations that have been long-standing have served us well. So, for example, we have a regional office in India that is 20 years old. We have trusted colleagues there. They trust us. For the last year, we've been training up infection control preventionists in India, over 10,000, within these collaborations within country. So when it came time and India was having challenges, we were able to mobilize those collaborations. We were able to rapidly get oxygen canisters to India. Our work in CDC is really in our technical surveillance, our technical advice, our technical and scaling up capacity. And it really is critical to have those trusted people on the ground so that we are able, in times of crisis, like we also have done in the Congo and Guinea for Ebola just this past year as well, to be able to scale up in times of crisis. And so that is exactly what we're doing, and what we're looking for resources to be able to continue.
Okay, I know my time is up, but I'm going to make this one comment. I was pleased that the administration and the Ambassador Tai was at the WHO and talking about lifting the waiver on supplying India, South Africa, other countries with the opportunity for the benefit in a temporary way of the licensing, the patents, et cetera, so that they can deal with manufacturing. Your point earlier, it's not good enough for us to be 80, 90% covered and 20 to 30% in other countries, because we are at risk if that is the case. So, and look forward to working with you on that effort. Oh, I'm sorry, I was muted there. Congressman Harris.
Thank you very much, Madam Chair. And again, thank you, doctors, for coming before the subcommittee. And I would be remiss, I forgot to thank Dr. Redfield, a fellow Marylander, for the work he did at CDC. you know, the job sometimes you have to take slings and arrows, no question about it, because if you recall, he was highly criticized for suggesting that the Wuhan virus came from a lab in the Institute of Virology, castigated in the public media. And now it seems we're come 180 degrees around where that's actually something that we actually should look at if we are to truly determine how this got started and where it came from. But let me go ahead and just ask about and just to clear something up, by the way, because it was suggested that somehow Florida had kind of a bad response to COVID. I guess I don't know. I think that Florida actually has among the lower rates of infection, and despite the possible description of a vaccine rollout as hectic, it seems that the public health goal should be to get to a good result, and I think Governor DeSantis did. That's just my comment. I mean, and it's objectively backed up by objective data, which is what we should be talking about, is objective data. So let me just ask just a brief follow-up on gun violence, because last year in the 28 largest cities, there was a 36% incident increase in gun violence between June and October. Very briefly, any ideas what could possibly have resulted in such a huge increase in gun violence in our cities?
Thank you, Congressman. Dr. Harris, I also wanted to, I neglected in our first round to applaud you and thank you for all of your public service in trying to get people vaccinated. I did want to highlight that and thank you for that. We are actively doing research on firearm injury prevention as highlighted by the priorities of the National Academy of Medicine, the who, what, when, and how of gun violence, of injury, firearm injury, and we'll look forward to those studies.
Okay, no, thank you very much, because I think we have to get to the root of the increase in gun violence and then question whether or not it's because policing activities have decreased. Many police forces in my local jurisdiction, for instance, have up to a third of their positions vacant because you can't find someone who wants to be a law enforcement officer anymore. The other thing that I wanted to ask about is the data. As you look at robust data collection, I would hope two things. One is that you do it obviously across the various parts of the CDC and bring it into what you suggest, Doctor, should be the way we collect data in 2021, not on the backs of envelopes, and develop a robust system, because it certainly is necessary. But as part of that, I do hope that you look at what went on with nursing home deaths in New York during the COVID epidemic, because I think we owe it to our seniors to understand what appears to have been data manipulation in New York. And I think we need to get to the end of it. Now, I'll just close out the last minute and a half and ask you to update us on Zika, which we haven't heard about for a while, thank goodness. Zika, and very briefly, you in passing mentioned Ebola, but we know that it's still simmering in Africa. What are the threats of these two diseases right now to Americans?
I'm going to pass that to Dr. Schuchat, but just sort of comment and say that among the things that I think that is critically important is the investment in SETNet, which is the review of maternal mother-baby pairs, which I think helps us evaluate not only Zika, but also COVID-19. Dr. Schuchat?
Yeah, I think there are a lot of lessons from the Zika epidemic. You know, a virus that had been recognized many years earlier with a mild syndrome, but a lab test that was developed because of that initial outbreak in YAP. And then, you know, the introduction into our hemisphere and the terrible outbreak in Brazil, and then in many other countries, including southern US. That reminded us how important it is to have entomologists in public health, a discipline that had been lost, and to have surveillance at the local level for mosquitoes. We know there are a lot of threats right now in mosquitoes and ticks and other vectors that can be the carriers of new diseases to susceptible populations. So the result of the Zika work was strengthening that infrastructure that we have with some centers of excellence the SetNet that you just heard about that helps us track not just Zika, but other threats like opioid related harms, or syphilis, other things that can affect mothers or babies. And so it really gets back to the public health infrastructure and the need for sustained focus. We get investments and then we lose them, and then we're surprised when a new threat takes us without preparation. I can tell you from meetings at the World Health Organization, they were very concerned about loss of resources to be able to continue to understand Zika as it hit newer communities that hadn't yet been through what we went through in the Americas. So I just think the emerging threats are out there, and that we need systems that are agnostic to pathogen or agnostic to disease that protect all of us.
Thank you very much. I yield back.
Congresswoman Lee.
Thank you very much. For Dr. Shuckett, one lesson that we learned during COVID-19 was the need for consistent, standardized, disaggregated, culturally appropriate data collection methods to really determine how to address and where to address targeted resources for medically underserved communities. Now, this was a heavy lift. We put this in all of our legislation. We asked CDC to collect the data, to work with states to give us the information as it relates to language, and to disaggregate the data based on race, ethnicity, gender, socioeconomic status. We never really, I don't think CDC ever took us seriously. So I'm wondering now, where are we in terms of data collection? Because we have to know, not only for COVID, but also for any healthcare initiatives that disproportionately impact people of color. And then Dr. Walensky, let me follow up. I wanted to just ask you, following up from Congresswoman Bonnie Watson-Coleman's question on HIV and AIDS. You know, we had an HIV/AIDS national strategy and plan. We went around the country seeking input from impacted communities to develop this plan. And I'm wondering if we have an update of a national HIV/AIDS strategy plan, and if we have a point person in the White House who's really putting all of this together and coordinating it. Dr. Shuckett.
Yeah, thank you. I really appreciate the attention that Congress gave to race and ethnicity and socioeconomic variables. And it was a tragedy at the beginning of the epidemic how behind we were. We are not done with improvements, but this has been a very high priority for the administration and the CDC, and we have made it a priority for state and local public health. They are somewhat hamstrung by what data they have access to, and so we've been trying to take a systematic approach to address both tracking cases, hospitalizations, deaths, as well as vaccinations in a way that gives us complete, actionable information. We've been using something called the Social Vulnerability Index, which is really driven where we try to get vaccine access to be improved, and that has borne results. We've seen a narrowing of the disparities of who's getting vaccinated. We've deployed through partners with HRSA and FEMA to get federally qualified health centers out in the areas of greatest need, to get the pop-up and the mobile clinics that FEMA is facilitating into the areas of need. In our pharmacy partnership, we've been reaching much greater percentages of individuals who reside in high social vulnerability index areas. We've been looking at the zip code level, not just the county level, to get those resources out. And I just really applaud Congress for saying this is important, you got to do it, and us being able to have the resources to try to follow up. But
Thank you. And I'd like, we only have a couple of minutes left to get a report back from CDC at some point on the status of what we asked for in all of the legislation as it relates to data collection, if that's possible.
Yes, and we've been providing a monthly update on the data systems, but I think a more comprehensive one, I'm sure we're happy to follow up on.
Thanks a million. Dr. Walensky, what about, and I'm, like you mentioned earlier, we've known each other for many, many years as it relates to getting a handle on how we achieve an AIDS-free generation by 2030. So have we updated our national AIDS strategy, and are we coordinated now with the White House in implementing one, if we have one?
So what I know is I used to use that AIDS strategy as my research Bible. These are where we needed to study. So I'm very familiar with it. I'm not I don't believe we've yet updated it in this administration. Of course, this administration for the last 4 months has been really focused on making sure that we can get out of COVID so that we can focus on other areas of health. But I do know that in the months ahead, when COVID is no longer what we're doing most of the time, that this is a high priority for this administration. I will look forward to that.
Okay, thank you. And Madam Chair, I'll yield the balance of my time. And thank you again, Madam Chair. Thank you.
Thank you. Congresswoman Herrera Butler.
Thank you, Madam Chair. I wanted to go back to maternal mortality. I know that was discussed a little bit earlier. In my district, 2 of my counties, Skamania and Pacific County, are considered maternity care deserts, and Lewis County, which is near there, is classified as having low access to maternity care. And lack of access to care stops women from receiving care that they need, especially those struggling with mental health and substance use, which I've seen a spike in those counties and in that area. So a 2020 or 2019 report found that the rate of maternal mortality in the U.S. could be even higher if we consider suicide and accidental overdose. And as you know, our rates are not good. I wanted to ask how the CDC is going to work to help the state MMRCs, our maternal mortality review committees, build their capacity to collect data on mental health and substance use issues. Obviously, they're investigating the deaths, but I want to make sure that we're collecting more and complete data to better understand that piece of substance use and mental health problems.
Thank you for that question. The high rates of maternal mortality in this country, to me, are inexcusable. This is something that we have to address. I think you commented on the MMRCs. Not only are we interested in focusing and expanding the depth of what they do, including mental health, but also the breadth, because they're not covering every area, as you note. And so we are interested in resources to do both, expand the breadth and expand the depth in mental health as well. I know you're aware of the He or Her campaign, the campaign to make sure that people know and understand and can see the warning signs in the pregnancy period, in the peripartum period, and the postpartum period. And those are all parts of the efforts that we intend moving forward.
Awesome. I'm going to switch gears to kidney transplant patients and probably others who are in a similar, solid organ transplant group who are immunosuppressed. Most of these folks have spent the last year in deep isolation to protect themselves from COVID. And the immunosuppressant drugs that maintain their transplant is making them uniquely vulnerable to severe COVID infection. And now, as the vaccine becomes widely available, it's been reported that patients on these immunosuppressants obviously may not be creating the antibodies anticipated after receiving the vaccine. What is the CDC planning to do for these communities who are following all the guidelines, getting vaccinated, but still may not be protected?
Thank you. I cared for these patients last year. So I'm deeply aware of following these patients, their worst COVID outcomes, and now the challenges associated with how we care for them moving forward, given that vaccine may not be protective. We know this is true of a lot of vaccine preventable diseases, both in the oncology world before transplant, as well as in the transplant world as well. And there's a whole discipline of transplant infectious diseases for exactly this reason. And in fact, what you're raising is not unique to kidney transplant. This was studied out of Hopkins. Dory Segev demonstrated it's many different kinds of transplant, and it's not just unique to transplant. They also demonstrated that dialysis patients, even before they were transplanted, that didn't have as robust an immune response. We continue to learn an extraordinary amount about these vaccines, who they protect, how long it lasts, and what we can do about it. We have very much indicated that we will continue to need, those patients, in order to remain protected, will continue to need to mask until we understand this further for their own health.
I think when it comes to the masking piece, one of my family members is immune compromised, and I also have small children. So I understand that tension between public and the need for my younger kids to have that access to social emotional development, but also want to protect one of my other kids who obviously a vaccine isn't going to do it. So I understand this. I think I think the data really has to lead us, and that's a really easy thing to say, considering I recognize there were challenges with the last administration in politics. There's challenges with this administration politics. That's the name of the game. But making sure that you, as the director, the CDC director, it is all backed up with policy based on the data. I think is going to give us the best path forward when no one knows all the answers on this. I don't think anybody's expecting you to do that. But the trust, to me, is the most important thing, is making sure I know I can trust the data and the recommendations that are coming out, and I can back those up at home with my constituents as well. So thank you for that.
Thank you. And maybe what I will just add to say is, for those who can't get vaccinated, or for those who are not going to have a robust immune response, the best protection we as a society can give them is to have everybody else around them vaccinated.
It's true. I have my shot. Thank you.
Thank you. Yes. Congresswoman Clark.
Thank you. And staying on children and the pandemic for a moment, we know that kids are at a lower risk for severe infection, but my understanding is that COVID-19 has also become one of their top 10 causes of death in this country, which is, of course, a cause for alarm. What do you see as the benefits of vaccinating our children and youth? And when do you expect to have enough safety data available to vaccinate a child of any age?
Thank you for that question, because I do think that some of the data and numbers are hard. You know, it is the case that a young person may be less likely to die of COVID-19 than an old person, but a young person is less likely to die of anything than an old person. And so comparing these are not always easily compared. And when you say like it's one of the top 10 causes of death among young people, that I think really does highlight the importance of protecting our children. And so of course, I want to see what the clinical trials demonstrate and what the data shows, and the safety as they do these scaled down trials down from age 12 to age 9 to age 6 to age a year. As we look at those and we see the trial data that demonstrate they are both safe and effective, I think there's an extraordinary role for vaccinating our children to protect their own health, to protect their family's health, and to protect their community's health.
Do you have any sense of a timeline, or is that just too hard to really know at this point?
My understanding is they're looking for a timeline late fall, early 2022 is the last that I've heard. I don't know whether that will be the entire spectrum or whether that'll be like down to age 9 or age 6. Some of this really, I hate to say it, it depends. You get outcomes in these trials when people, you know, in the placebo arm get infected. If there's less disease out there, you have less infections in the placebo arm. So really, it does depend on where we are with the pandemic too.
Okay. I also wanted to talk to you about recently the World Health Organization urged that wealthy countries like the US postpone vaccinations for children in order to donate more doses to COVAX, the vaccine sharing initiative. Is your agency concerned that vaccinating our children will detract from participating in being a partner and ending the global pandemic? And sort of how are you approaching this balancing act?
I think we have to do both. I think we were the country with the largest number of deaths across the world due to COVID-19. This was a put on your own face mask so that you're able to help others. And that's what we're working to do right now. We are actively scaling up in our efforts, not only to provide funds to COVAX, but also to provide vaccine. As I mentioned, 80 million doses. We at CDC are now working as those doses get donated and implemented with countries so that we can help them in immunization programs, help them with vaccine confidence, help them with adverse outcome event surveillance, and to do all of the work that we have been doing here in this country scaled up around the world.
Great, thank you. And in my brief minute left, I want to go back to talking about data collection. And we know extensive evidence showing communities of color are disproportionately impacted. Dr. Schuchat, I wonder if you can tell me how CDC's data collection has changed and how are you working to make sure that we are collecting impact data on communities of color and disaggregating that data. I'm sorry, there's like no time left, basically.
This is such an important issue. If we don't know where the problems are, we can't address them. And so the public health data modernization effort needs to reach every community with trust and with skilled systems, skilled people working on skilled systems. We have made progress this past year with increased completeness of race ethnicity data. We have much more timely mortality data now. The laboratory reporting has gotten to be quite speedy, but it's usually missing all the information we're interested in. So some of our highest yield focus areas now relate to electronic health records and other data systems that can be linked to the public health information so that we can have complete, actionable, timely data. So a lot of progress, but a lot more to do. And we do think this really needs to go beyond COVID because the next thing is not going to be COVID. We're not done with this, but we can't develop a beautiful, perfect, pristine system for one disease and then have everything else fall behind. You recall with the EVALI lung injury problem, just a couple thousand cases really exhausted our data capacity. Now with many millions of cases of COVID, we've learned that we have to scale, we have to have the systems and the workforce that can handle them.
Thank you. My time has expired. I just want to thank you again, Dr. Schuchat, for your remarkable service. We're very grateful. Thank you, Madam Chairwoman.
Thank you. Thank you. Congressman Klein.
Thank you, Madam Chair. I understand the need to ensure that we vaccinate as many as possible, and in considering that, we also want to make sure that our children are kept safe. But I am concerned that in the effort to keep children safe, by going beyond vaccinations to continuing to keep lockdowns in place, continuing to keep mask requirements in place. My colleague from Washington spoke to it earlier. We are doing just as much harm as we are potentially doing good to these children. One thing we do need to remember is that when we're talking about COVID deaths, of the 500,000 deaths in the United States involving COVID-19, as officially reported by CDC, 238 have been in children 17 and younger. That equals 0.04% of all COVID-19 deaths reported in the United States. So we do have to make sure that as we consider protecting our children, we also consider the effects of locking down too much, keeping them out of harm's way in excess. And to that end, I would ask, do you have statistics on the suicide rates of children over the past year and how much that has risen?
Thank you for that question. I don't have them off the top of my head. My understanding is that there have been increase in mental health challenges with children, increase in emergency department visits. It's not yet clear, and the research will show in the months and years ahead, whether and how much those are related to lockdowns or other adverse childhood events that are associated with this pandemic, such as food insecurity and parents losing jobs and whatnot. One thing I do want to highlight, and I want to just make sure you understand where we're aligned, is I very much believe that all schools should be open in person, full-time, 5 days a week come the fall. And we have put extraordinary resources and measures and outreach to make sure that that can be the case through teacher vaccination through the month of March, which was able to vaccinate over 80% of teachers, and through testing initiatives so that we, in places that cannot vaccinate younger children, we have routine screening testing in the schools, extraordinary resources and efforts that are science-driven so that we can make sure that our schools are not only open full-time in the fall and are safe to do so.
Okay. I want to shift over to the study that you all are going to be undertaking into gun ownership. The last study you all undertook was in 2013, I believe. I'm concerned about some bias within your organization regarding gun ownership. So I want to confirm right from the start that underpinning this study will be a recognition of the right to bear arms as a basic human right established in our Constitution and affirmed in D.C. v. Heller.
Congressman, I don't know the specifics of that study. That's not one that I'm familiar with. I'm certainly happy to have our staff get back in touch with you with regard to the details.
Okay. Well, can you commit to me that that will be an underpinning in the study that your organization undertakes as a result?
You know, I would like to understand and know the study before I speak to it.
Well, you all were just appropriated funds to study gun safety.
Yeah, maybe I can clarify. In 2020, we received funds to be able to reinitiate proposals for research on firearm safety, gun violence, et cetera, and have.
And when was the last one?
Yeah, you're right that this was suspended since the 90s, I believe.
2013 was the last one that came out, I believe. The Obama administration issued an executive order to conduct a study regarding gun safety.
Yeah, that I'm not familiar with the details, but what I can say is that we do not do advocacy. We are funding evidence-based research, and the funds for research that we have put out have followed the research gaps that were identified by the National Academy of Medicine. So that's the nature of
well,
the research.
in my closing seconds, let me just urge you to speak to the benefits in addition to any risks associated with gun ownership that law-abiding gun ownership provides to society as a whole. The defensive use of guns by crime victims is a common occurrence, although exact numbers do remain disputed. Defensive gun uses by victims are at least as common as offensive uses by criminals. Estimates range from about 500,000 to more than 3 million per year in the context of about 300,000 violent crimes involving firearms back in 2008. So there is a way to look at this issue from a balanced perspective, and I would urge you to do so. Thank you. I yield back.
Thank you. And if I may a comment to my colleague, because it has been on my watch in which we have really held the first hearing. And please understand this, it's gun violence prevention research. And it is about the public health crisis. And the amount of research has been, there has been no research in the same way that we've dealt with automobile accidents and crashes, et cetera, and what that did in terms of helping to prevent the loss of life. And this is research that is, I guess it was our colleague, Congresswoman Lawrence, who talked about a public health crisis in this area. And that is what the research is focused on. I will give you, and we had an entire hearing, and I'm happy to provide you with the transcript of that hearing with this. We are not looking into, or the dollars appropriated, we're not looking at gun ownership. The issue is, how do there are more suicides than homicides. Why do we have suicides? And those suicides are the highest number are with our veterans. Why is that happening? If we can store guns as people across the board from wherever position are in a better, safer way, would that cut down on gun violence? So that is the basis of the, and we can provide, again, as I say to you, what is in the legislation, the language of the legislation, which lays out what the scope and the mission of the resources are for the gun violence prevention research. And with that, let me recognize Congresswoman Frankel.
Madam Chair. Yeah, I mean, sadly, as we are speaking here today, there is a mass shooting happening right now in California, in San Jose. Madam Chair, I just want you to know that I actually live in Florida. I don't know if you knew that, but I do. I
know.
There have been so many questions. So to our guests, so thank you very much. If this has been asked, just say, okay, you missed it. This whole issue of the vaccine passports is starting to become a little controversial, especially in my state where I live, Florida. And I would just like to get your feedback on that, on the use of requiring, a vaccine passport to go into certain establishments or cruises or so forth.
So the federal government has made the decision not to be the leader in vaccine passports, but has said that local communities, private sector may use it for their industry if they so choose. I can envision that there would be certain sectors where this would be incredibly helpful. And for example, cruise ships, I think, would be one of those where where cruises would like to be able to know the status of of the people who are taking a voyage. What I will say is that the most important thing is that people get vaccinated. And if there's a lot of people who are getting vaccinated, the utility of this passport, in fact, if everybody gets vaccinated, the utility of these passports is nil, right? So really the most important, the reason that we even have to have a discussion about passports is because people are not getting vaccinated. But if we can get people vaccinated, then the importance of these passports really diminishes entirely, or these verification mechanisms really diminish entirely. Yeah, I'll just stop.
Okay. And if you could get us, maybe someone on the staff can get us that confidence hotline number, that would be helpful.
Be happy to do that.
Yeah, I'm going to just switch the subject for a moment, which I want to talk a little bit about domestic violence, because I know that you have a program, I think it's called Delta. You also manage the rape prevention education formula grants, and I'd like to ask you a little bit how that is going, what kind of progress is being made.
These are such difficult issues for the individuals involved and those who love them. There are, CDC's been developing technical packages, the toolkits of what we know works, the evidence base, and facilitating that to be used by communities around the country. And we have funded additional programs to sort of scale up these efforts. Things are different in one place or another, and sometimes, whether it's rural or urban area, the nature of the challenges are complex. The team working on this is incredibly dedicated and empathetic in their carrying out the research efforts, but mainly what we're doing is supporting programs to implement evidence-based strategies.
Thank you. I'll give one a softball question. I know we've been talking a lot about COVID and AIDS and other diseases and so forth. What, in your opinion, are the top healthcare issues that face Americans today?
I'm not even a good hitter, but I'm going to take a swing. We need to bolster our public health workforce, our public health infrastructure, our workforce, our data, our labs. We need to work on health equity in this country. Everything that we do has to be founded in health equity in this country. We obviously need to get through this COVID-19 pandemic and get everyone vaccinated. And, we have a lot of work to do in opioids. We have a lot of work to do in HIV. We have a lot of work to do in mental health. We have a lot of work to do in health losses that we saw during this pandemic. 11.7 million childhood vaccinations have not been given. So I look forward in leading this agency through this pandemic and to address all of the public health infrastructure of this country.
Thank you so much, everybody. I'm going back to the beaches.
Wear sunscreen.
Very good.
Maybe
They
this
deal with
weekend.
that issue as well, Lois. I think, I don't know that there are any other members for questions, because that I would, if there are not, what I would want to do is to yield to Congressman Harris, and if you'd like to be, and recognize you for any closing remarks you'd like to make, Dr. Harris.
Yeah, thank you very much, Madam Chair. And as usual, some of the hearings we have in this subcommittee are the most fascinating hearings, I think, in all of Congress, to be honest with you. I want to thank again the doctors for being with us today. I want to say that the CDC, obviously, look, the CDC plays an incredibly important role in the interface between science and the American public to a large extent. The American public looks to leadership in the CDC, grounded in science. For an example, I'm glad to hear that the federal government's not going to get involved in vaccine passports, because we have to admit there is no data that vaccine passports would contribute anything right now. There's just no data. Now it might, and it might be tempting to think it would, but it was very tempting to think that fomite transmission was also very, very important at the beginning. It kind of made sense. Look, I used all the hand cleaner in the world. Turns out that's not really as important as we thought. But there's a big difference between making someone carry a vaccine passport and making someone clean their hands with hand sanitizer. And I think that this is where the difficulty lies in public health, and kind of treading that fine line between what really will help people and recognizing that there are civil liberties in this country. And that's the best way I can explain it. So as again, Dr. Walensky, as you said, I'm more than happy to help staff vaccine clinics, and I've done it. But in the end, it is an individual's choice to get this vaccine, because it is an EUA. It's not an FDA-approved vaccine. I encourage the vast majority of people I speak to get it, but in the end, it's their decision. And I think the CDC has taken a tremendous step in their mask mandate removal or mask guidance removal for people with vaccines, because I think that engenders a lot of confidence in Americans. Finally, a lot of Americans I meet with say, wow, yeah, my common sense is I got in line, I got the vaccine, now I should be able to take my mask off, and now our policies are aligned on that. And I think that sent a very important signal. I think that's why we're approaching the 70% mark in adults being vaccinated. And of course, that combined with the natural immunity, we should be pretty near herd immunity. And I think that's what the figures are beginning to show now. So thank you all for the work you do. It's thankless work, as has been pointed out in your testimony. Public health officials are underpaid relative to their skill and training. This leads to some problems. There's no question about it. There's no easy solution. But hopefully some of the budget things you discuss for the FY22 budget will get us in a better path into getting the public health workforce that we need for the 21st century. And again, Madam Chair, thank you again for fascinating hearing, and I yield back.
I want to thank Dr. Harris for his comments. I think I agree. Not in a self-serving way, but I think that this subcommittee has the best hearings. And I think between yesterday and today, there really is, I used the word yesterday, exhilarating. I mean, what we learn and what both an NIH and a CDC can do to save lives, to keep people healthy in this country is quite remarkable. And I think it's a hallmark of the United States in terms of our healthcare system. I'm going to ask both Dr. Walensky and Dr. Schuchat to be absolutely singularly, like in the nanosecond. What keeps you up at night?
variants and the concern that people won't get vaccinated and the fact that we're not serving everybody in the country equally.
Yeah, okay. Dr. Shuket.
I think we have to remember the rest of the world, and that while it's getting better here, there are many places at risk. So until we're all out of this, none of us are out of this.
Thank you. Thank you very, very much. Really, I think we covered some very important topics today. And I wanted to say this, historically, the CDC has been the trusted voice in leading the response to public health crises. And I will say this, and look, whether it was Ebola, Zika, lead poisoning, and so many others. I think we saw a recent departure from that standard. So I want to just say a thank you, a real thank you to both of you and CDC for returning the CDC to be that trusted voice and relying on the science and the data that is necessary to create the confidence in this country that we do have the agency that they can take a lead from. People want to know the truth. They need to be given the truth, and then we could look to how we can direct them. I would again add that COVID exposed a number of realities in this country. We need a robust public health infrastructure. We can't go back to where we were, and we have to go forward. So we look forward to receiving the comprehensive president's budget. That's later this week. And then the subcommittee has the challenging task of addressing so many critical issues included in your bill. And it's remarkable the range of issues that you look at. We've talked about some of them today. Maternal mortality, but you do food safety, you do so many other things, and and it is immunization and mental health and opioids and HIV, and doing all of that work at the same time of dealing with a pandemic. So we want to provide the resources that you need, and we'll continue to fight for that sustainability that I think has come through as the thread of this hearing today. And that for the CDC to do the job that we want them to do, you need to have the continued resources, not for this, just for this pandemic, but for whatever else comes to pass for this country. So thank you. And with that, this hearing is adjourned.